In?
Yeah. Hi there, we are back with a progress update on D2D. We are just letting the remainder of the participants enter our room, and then we're going to get started. We have an exciting session today planned for you all. And Erin, give me the okay when you think everybody has made it into the room.
Okay, I think you're good.
All right, so sharing strategies, successes, and secrets. Next slide, please. So today, we are at a benchmark in a way. We've done this for a year. All of us have learned a tremendous amount. We've had many successful teams in this. And it's time for us to get a little bit of more formal feedback from you. And that's why we're inviting you, first off, to take a brief D2D implementation survey. And to access the survey, please go to the chat box right now. I promise it won't take that long. And click it on and complete it. And that'll take at the most 2 to 3 minutes, and then we'll move forward with our speaker, Dr. Monica Ott, today.
And if you're joining, I was just going to say, if you're joining by phone and unable to access the link, it was also included in the Drive to Deprescribe email that was sent yesterday. So you can complete that whenever it's convenient, and we'll include it in the follow-up email next week.
All right. And as you know, in all of this, we've been really trying to be conscientious about making this actionable and practicable for you. And we just want to make sure whether we reach that goal. We will be sharing the results once everybody had a chance to vote by next D2D session. So poll masters, can you give me the go ahead to proceed, or are we still having folks coming in?
Well, we're not able to see how they're
Oh.
doing it because on a website, so we can probably move along now, I think.
Is there anybody else who would like to? No, I need another second.
And the poll will remain open, so you can complete it either during the
okay.
call, after the call, within the next few days. We just figured we'd give everyone a little time.
Okay, great. All right, next slide, please. So again, our ground rules are that we really, and especially in this type of session where we have somebody who's sharing their experiences with us, we want you to participate in the chat. We'll be monitoring the chat. We'll be answering your question in the chat and live, and we'll hope to give you also references. So please make abundant use of the chat function. Next slide, please. So with that, I'd like to introduce our speaker, and many of you probably know Dr. Monica Ott. She is currently the Market Medical Director for Indiana and Missouri markets of Senior Community Care with Optum. And she leads the medication optimization, pretty clever, Monica, initiative, and works with the education team on clinical topics for the advanced practice clinicians such as COVID-19. And prior to joining Optum, Dr. Ott worked for 10 years in the Department of Internal Medicine and Geriatrics at Indiana University, actually together with Dr. Nazir, teaching medical students, residents, and geriatric fellows. She's board certified in family medicine and geriatrics and has been at AMDA for many years and is a CMD served on the Clinical Practice Guidelines Committee, and past am the Indiana chapter president. And those are wonderful and incredible accolades for Dr. Ott, but really what Dr. Ott has also done, and that's what we want to talk about, besides all these experience, she is also being a medical director. And she has approached the challenge of deprescribing antipsychotics personally in a nursing home. And that's what we want to, that perspective is what we are incredibly interested in now. And she's going to give us a little overview on how she did it. And I want you to, all the questions you have about implementing, she probably has a lot of answers. So Dr. Ott, please go ahead. You have the floor.
All right, well, thanks for having me today. As Dr. Von Price mentioned, I have done this before, did this at multiple medical facilities. So next slide, please. Probably the most important was when I was at a facility that started out as just a general long-term care facility, and they actually decided to convert their 110 beds into dementia only. And when we did that, obviously there were a lot of things that happened and had to shift. And so one of the things we started doing were these interdisciplinary team meetings every month. Once you get your process going, you can certainly change that to quarterly, but it also depends on the number of patients you need to review. So obviously, if you're in a dementia building, everyone has dementia, whereas if you just have a dementia unit, then you may have less. So we would review the different triggers that the patient was having for the behaviors, and then also things we would look for to reasons to do a gradual dose reduction. But reviewing the medications is really just one part of it. And what we came to realize was that we didn't really have an appropriate activity schedule. A lot of the nursing home scheduling is unfortunately related around Bible, bingo, and birthdays, which there's nothing wrong with those three. But it's
B's?
The 3 B's, yeah.
Okay.
But it's really not enough. And there tends to be a lack of male programming. So there really needs to be male and female programming. There needs to be active and not so active. There needs to be larger group, smaller group, hands-on. And the more advanced the dementia, the more, the smaller the scale has to be for these activities. And setting someone down in front of, a movie for 2 hours isn't going to work. Most of these activities need to be about 30 minutes in duration. So appropriate activities are really a huge part of prevention. The other thing is you have to have relevant hands-on dementia training. So in Indiana, they do have a couple of hours of required dementia training, but they don't specify what that has to be. And one facility, their idea of dementia training for the staff was to have them watch The Notebook, which is a great movie, but unfortunately doesn't really help people learn how to work with folks with dementia. So really needs to be relevant, needs to be hands-on training. So once you have those 3 components in place, you set yourself up for success. Next slide. So I think it's important to understand reasons that you want to do the gradual dose reduction and reasons you would postpone it. Notice I don't say don't ever do it. What I'm saying is that now's not a good time. So things we don't always think about is sometimes we start a medication and it doesn't work. So if it's not working for that behavior, you certainly want to get rid of it. There are some indications that may seem good, but when surveyors come along, they're very likely to give you an F tag if you use something like wandering or memory loss. Those are just not considered acceptable. If the patient has a prolonged QTC, particularly if they're on other medications, then you could manage the behavior some other way. You really should. The family or the responsible party need to understand that all of the antipsychotics have a black box warning. So does Depakote, by the way. So if the family says, I'm not willing to take that risk, then you really need to get rid of it. And then also there are certainly patients that are going to get side effects. And we used to think of just tardive dyskinesia for the old style antipsychotics. But realistically, even the newer generation ones can do this. I've seen some really severe dysphagia occur from use of risperidol because it's very anticholinergic. And it's not the only one. So just make sure that, if you have one of those, you really want to do the gradual dose reduction sooner rather than later. On the other hand, if I had a patient who had a recent inpatient psych stay, and you could define that as 3 months, I usually define it as 6 months. If you have a recent failed GDR, so if they failed in the past 3 months, I would postpone it. If you've tried to GDR another psychotropic medication within the last few weeks, I would hold off. I'm not a big fan of doing gradual dose reductions of multiple medications at one time unless they're truly having side effects. Now, if somebody's lethargic, that's a different situation. But in the sense that if they seem to be doing okay, I try to do one at a time. On the other hand, if the family says, I don't want you to take them off it, the last time you took them off it, they ended up in the psych hospital. Again, you might want to consider postponing, but you're really going to have to document very well why the family's requesting that and why you agree with them and you think it's appropriate. Again, doesn't mean never, just means not right now.
Monica, may I interrupt here? This family request is something that we all deal with frequently, I think. In fact, many of the patients that I have those family requests. What's been your most successful approach there?
Well, there's kind of two camps. There's the family that says, I don't want you to put them on anything. And then there's the family that says, you can't take them off. And so the approach is different for those. So for the family that says you absolutely cannot put them on this medication, first of all, my philosophy as a geriatrician for the antipsychotics is usually you use it more like Tylenol when you need it, but when you don't need it, stop it. There are some providers you'll run across who are like, absolutely not. If they have dementia, I'm not giving them an antipsychotic. And then some people are fairly willing to prescribe these kind of medications. I think there's a more of a nuanced approach that's appropriate. So generally speaking, by the time I was recommending an antipsychotic to a family, the patient was basically at a situation where they were either going to have it in the facility or they were going to go to a psych hospital and the psych hospital was going to prescribe it. And so those, you know, and again, at that point, I'm not sure that either one is a great option, right? In terms of family saying you can't get rid of it, that's a more of a nuanced conversation about getting them to understand that there are risks. And going through very specifically, look, these medications have a black box warning in patients with dementia. And the reason is they have increased risk of stroke. They will die sooner. They have increased risk of cardiac events, arrhythmias, etc. So I think just making sure that they understand that you're really wanting what's best for the patient, and as much as you can, trying to understand why the behavior is happening, how to prevent it, and then how to address it, particularly without using medications. But also validating their experience that they've watched their loved one have problems, and they don't want to see that, that distress. That's essentially what you're seeing, is that distress. And so again, it's really good collaboration and good communication, and it's not easy, and it's not a one and done conversation usually.
Yeah, I think validating the experience and giving them the acknowledgement that we hear them is really important, because many of those family members probably have witnessed significant distress.
Right.
Thank you.
Okay, next slide, please. So I created a process when I went into another building after I'd been at the dementia only building for about 5 years. And unfortunately, at the building that I transitioned to, about a lot of the patients were on medications. And in fact, they were on for very strange reasons. One I specifically remember was a patient was refusing to take insulin. And so the provider decided to start an antipsychotic. And I thought that was just really crazy. So again, we would review the patients. Initially, we started with monthly, and then once we got into a better pattern where we were able to reduce the numbers by 50%, we went to quarterly. The important thing is really understanding what exactly is triggering the behavior, and then how do you prevent it, and then how do you mitigate it. So for example, if you know that the person gets triggered by putting them in a large group activity, then you would avoid large group activities. And if it turns out that the person said, oh, I do want to go to that, large activity, you'd have them kind of in the back of the room where you could easily assist them out to a quieter space if they got overstimulated, just as an example. The key here is that you may want to do a gradual dose reduction on every single patient on that particular unit or in that particular facility, but realistically for the nursing time, 1 to 2 patients per unit per wing is a lot more realistic. The nurses need extra time to document because you're doing the gradual dose reduction. The other piece that has to happen is the nursing staff have to implement the non-pharmacologic measures. And as much as we would like to say that's straightforward, it isn't always. And so trying to get their cooperation and their buy-in makes sense. And of course, there is a risk that, the person's going to escalate. And what you don't want is to have, 10 or 15 patients on the unit escalating at the same time. So generally speaking, I would do, 1 to 2 residents attempted a gradual dose reduction per unit or wing or whatever, however your facility is divided up per month.
I think that's a really important pearl. Sometimes it may not be possible because they're due for a GDR, but I think that's a really important pearl. Don't try to reform the entire unit if you must. Just go gradual, because it's easy for us to deprescribe. It's a whole other thing for the nurses to implement other alternatives.
Right, and we're going to talk more about that too.
Okay, great.
Yeah, next slide, please. So there are many different theories out there for why behaviors happen. My favorite is really Unmet Needs by Cohen Mansfield. Again, there are other ones out there. What I recommend is really looking at things from the CNA perspective, the nursing perspective, the social work perspective, and the provider perspective. And you start with easy things. So is the person overstimulated? Are they understimulated? So maybe there's not an activity going on and they're bored. I can tell you that if a patient with dementia is bored, they're going to find something to do, and it's probably not what you want them to do, whether it's peeing in the potted plant or wandering into somebody else's room or taking all of the shoes on the unit and collecting them. Whatever it is, they will find something to do. The other issue could be that the task is too complicated. If the CNA just hands them the toothbrush and the toothpaste and says, brush your teeth, and their dementia is more than a little mild, they're going to have trouble with that. So you need to kind of break it down and make that more discrete steps for them. You have to understand that a lot of them have vision and hearing impairment, so accounting for that as well. And then for the other things, it's the CNA should be aware, is it likely that the person is hungry? Is it likely that they're tired, that they need to use the bathroom, they're hot or they're cold? But then, from a nursing assessment perspective, is it possible that this person is having a new illness? Could they have a bladder infection? Could they have pneumonia? Could they have depression, constipation? And then, having social work, do their assessments. And is it possible that this person's having more anxiety or more depression? Or is this a side effect of a new medication? So then what you want to do is, once you identify what you think is triggering the behavior, then you want to try to, prevent the behavior. For example, if somebody tends to go, help me, help me, help me in the dining room after eating, because they need to be toileted, then your care plan would reflect that they need to be toileted after eating, rather than being left in the dining room for an hour or so while people are, going back to their rooms. You'd want to prioritize that person going back first. Then basically what you do is you monitor. So did it work? Because a lot of times your first thing that you try doesn't work. I think on average it took about 10 tries for some of these things. So it's hard to, stick with this when the first 1, 2, 3 things don't really work out. But really, I preserved the antipsychotics for when I really thought that the issue was not related to what I was doing, but it was really more of an internal hallucination, delusion, that sort of thing. That's when I would consider the antipsychotic, and really looking, is this a psychotic type of a symptom, and is it bothersome to the patient? So again, you're going to have patients, say, that have Lewy body dementia or Parkinson's disease with dementia, and they may see little bunny rabbits, but if they're not bothered by that, then you would just not buy into it necessarily, but you wouldn't use a medication for that situation.
I like how you broke it down. This is like an hour worth of lecture, really, and but I think you used it like that, and I really like it how you concisely did this here. Can you tell us why we chose the team members to be colored in green?
Yeah,
This was
so
something new
turns
to
out
me.
that patients with dementia recognize green first, and there probably is some physiologic reason for that, but I don't recall what it is, but they tend to recognize green. And so, if you have somebody where you want them to use their walker, or wheelchair, you'd put little strips of green on it for them to pay attention to it. But the important thing here is that if you as the provider are in the facility, 1 day a week or even 5 days a week, you're probably not there as often as the CNA and the nursing staff. And so really, they need to be the ones that tell you what's causing the behavior. They should be the ones to be able to, be detective and figure out what's going on. And then once you figure out what's going on, then you can better address it. But the answer is really not the easy button, which is, push the button, call the provider, and dispense whatever medication. When I was starting at this dementia-only building, my colleagues were geriatricians and not too excited about prescribing antipsychotics or other psychoactive medications to patients with dementia, and I understood that. And the nurses, unfortunately, there was a culture created before that if there was an issue, that they would just call the provider and get a PRN something, PRN Xanax, PRN Haldol, PRN whatever. And so what I would tell my colleagues was, if you get a call from such and such a facility and they're requesting a PRN something, just call me, because I really will address that. Because when they would call me during the day and they'd say, oh, doctor, at that time I had a different last name, but we'll just say Dr. Ott, hey, can you give me a PRN order for such and such? And I'd say, well, what have you tried? And invariably the answer was, well, nothing. And I'd say, well, I'm going to need you to try some non-pharmacologic interventions. And if that didn't ring a bell for them, I'd say, okay, I need you to try to see, are they hungry? Give them a snack. Do they need to be toileted? Are they overstimulated? You need to remove them from the situation. Whatever it is. And invariably, I'd never get a call back, because by the time they tried a couple of things, it usually worked or they got frustrated. And so what I would tell my colleagues was, just have them just call me. And so, of course, they would call my colleague on call. My colleague would call me. I'd call the facility back, and they'd say, but you're not on call. And I'd say, no, you're right. I'm not on call tonight. However, what is it that I can help you with? Oh, well, we wanted a PRN, whatever. And I'd say, oh, what have you tried? Pause, silence, nothing. Okay, so I'm going to need you to try something. This took about 2 weeks. After about 2 weeks, they stopped calling because they realized they weren't going to get a PRN, that they were going to need to find a way to deal with whatever was going on. And I would tell them, look, the answer doesn't lie in the provider who's there, 1, 2, 3, 4, 5 times a week. The answer is those who are working in the facility. It could be the person who does laundry. It could be the maintenance person. It could be the director of nursing, but more likely than not, the answer is going to come from the CNA, the person who spends the most time with them.
Well, I'm glad you brought that up, because I think just now we are, as a community, are recognizing, I think we've always known it, but I think there's more of a push to recognize the importance of the CNA for the overall team. And unfortunately, CNAs are not as involved in like meetings, etc. And my challenge is always getting that input from the CNA. Is there some tips you can give our audience on how to improve that communication with the CNA, both ways, either saying, going through these steps, or getting the information from them?
Yeah, so I would just go up to the CNA, especially if I was, making my rounds, the CNA was in the room. I would just ask them, how is Mrs. Smith today? How's Mr. Patel today? What have you noticed, if anything is different, and then I'd ask directly, okay, so, when do they do this? Help me. What do you think's causing it? And if they would say, well, I don't know, I'd say, okay, specifically, when is it happening? Is it morning? Is it evening? Is it night? How often is it happening? What have you tried? What's working, what's not working? And even if they couldn't necessarily describe what they thought the problem was, usually by their description, I could figure out what was more likely than not the issue. So I think sometimes you just have to directly seek them out. But during the interdisciplinary meetings, I would specifically ask for the input from nursing staff. And so if they couldn't tell me, I'd say, well, go ask them and then come back.
Okay. Yeah.
But that after the first meeting, they understood that I was going to ask now I understand your nurse, your CNA can't attend these meetings. That's fine. I don't want to take them away from patient care, but I am going to want their information. So before the meeting, you need to talk to them and find out, from the day shift, how's things going, from the night shift, how's things going. And I expect that information when we're having this monthly meeting.
Thank you.
Okay, next slide, please. So we've already talked about appropriate activities, and there's lots of resources out there on what are considered appropriate activities, but it's not the 9-to-5 schedule. That's convenient, I suppose, for staff, but the reality is that that's just not going to work. Having everybody leave the facility at 5 o'clock just means you're going to have a lot more issues from 5 to whenever they manage to go to bed or go to sleep. One of the other things is really getting buy-in from everyone. So if the nurses don't buy in, and for example, several of the nurses didn't buy in and they kept trying to go around me to get a different answer from a different provider, that's a problem. If you're the medical director or you're one provider, but there are other providers who don't buy in, that's going to be problematic too, especially if they can prescribe or de-prescribe. You really have to be on the same page. It's important for the administration to understand this. It's important for the family to understand why you're doing it. You're not just, checking boxes on the paper. I mean, some of us really hate getting those pharmacy recommendations, but this isn't about pharmacy recommendations. This is about doing what's right for the patient and making sure that their quality of life is as good as it can be, and that we're doing what we can to honor them as individuals, not just throw medications at a behavior that's really more of an attempt to communicate their needs. If you look at a cross-section of the brain of somebody with dementia, it looks pretty bad. There's a lot of brain matter missing, and it doesn't matter which pill you take. Antipsychotic, benzodiazepine, SSRI, the new favorite drug that I won't mention by name. It doesn't matter. None of those things are going to work once you're missing brain tissue. The other thing we learned when we converted this building to dementia only was you got to get the right staff on board. So they made a big fuss about, we want to make sure they're dementia certified. Well, I can tell you that what's the piece of paper says doesn't amount to a hill of beans. What you need to know is the person open, teachable, and are they somebody who doesn't get easily ruffled? So if you have, somebody who gets easily upset when somebody pees in the potted plant or takes their clothes off, that's not the right person for the dementia unit. You really have to be able to just kind of go with the flow. And you can teach people that, but they have to want to be teachable. It's important to understand that stopping or decreasing a medication today doesn't result in a behavior tomorrow. That's just not the way they work physiologically, pharmacologically. And the other thing is just even if that you think it might be related to that GDR you did 4 weeks ago, not to say, well, that's automatically a failure and they have to go back on it, but to really say, what else can we do or what else should we do? The other thing is prevention. I don't know why, but they decided to deep clean one of the residents' room when they normally nap. That's a really bad idea. Let the resident nap and deep clean their room later or before. And other things is because we were converting the building, we noticed that there's a lot of construction on the unit. There's a lot of noise. There's disruption to their regular structure and schedule. Not a good time to do a GDR. Just kind of postpone that. Construction doesn't last forever. So these are some of the things that I just wanted to highlight as keys to success.
I think you brought a wonderful list of subjects here. And one thing that I have always struggled or frequently and still frequently struggle with is that failure of the GDR. So I recommended GDR, it's implemented, and then I review those quarterly unless there's something specific, and then say, okay, well, how did the GDR go? And then I hear, oh, we stopped that. We're back. That was a failure. And it was just, it seems an easy switch to say this didn't work. So I'm really glad you brought that up, because you really need to do that same trigger analysis or that behavior trigger analysis, probably with that supposed failure as you do in the beginning. Would you agree?
Yeah, absolutely. So if we go to the next slide, I have some pearls for you.
Oh, I love pearls.
So 90% of the behaviors stem from poor approach. So if you haven't heard of Teepa Snow's positive approach, I strongly recommend you look for it. You can find it on YouTube videos. You can buy her DVDs. I really like them. I think they're great for staff teaching. In fact, the Alzheimer's Association realized how good her information was and actually then invited her to be a part of their education series. So clearly, if the Alzheimer's Association is endorsing her, you know you've got good information. And the staff don't want to hear that, though. They don't want to hear that they're contributing to the issue. But the reality is that how we approach people really matters. I could do very painful things to people, from knee injections to incision and drainage, and I would be fine. And others times the CNA would try to get them to take their clothes off, and they would meet a lot of resistance. And the difference is in your approach, you know. And so it's incredibly important. There are still, though, the 10% that's really coming from internal stimuli, hallucinations, delusions. And so sometimes, again, you need medicines for that. Sometimes you don't. As they get farther and farther into the dementia, it's less and less likely that they really need a lot of medications. As I mentioned earlier, behaviors are really communication. You need to be detective. They may only have the words, help me, or I want to go home. That may be all they're able to say at this point. And so, you know, I want to go home may mean I want to go home, or it might mean I need to use the toilet, or I'm hungry, or I'm lonely, or I want my mom, or whatever. And so you have to kind of decode that. If you argue with people with dementia, you lose. They are in their own reality, and you have to go to their reality. You don't have to like it. But they are in a different reality, and they say, oh, it's 1976. 1976, what a great year. You know, you don't go, well, it's 2022. You know, it doesn't matter. You're going to lose every time. Really, prescribe environmental modifications, first, second, and third line. And here's just some suggestions. You know, redirect, remove them from the situation, try a different staff member, try an alternative, offer some sort of a treat. There's so many of them I just put a few in there. And then again, my philosophy is with antipsychotics and patients with dementia, use the Tylenol approach. Use it when you need it, then stop when you don't need it. So on the next slide here, I have some references that I think you'll like. Bathing Without a Battle, this is with Dr. Sloan and his colleagues. You can get a book or a DVD. When I'm recommending to families and trying to get them to understand why they're having a behavior or why they're doing something specific, I recommend that they read Creating Moments of Joy. Jolene Brackey used to work, I think, in an activities role in the nursing home, and she has these really short 3-page chapters, very easy to read. Don't have to read it in order. You can make little notes on what works for their loved one. I don't have any stock in any of these, but I do recommend, that's my favorite one to recommend to families. For staff training, Understanding Difficult Behaviors is a good one. It kind of goes into these different categories of physical aggression, verbal aggression, sexual behaviors, trying to understand, you know, what's causing these things and then what can you do about it. If you want more academic information, the next slide has different references for, like I said, the Cohen-Mansfield and their unmet needs. Hasibo is a good one, and it talks about, you know, if you treat pain, you get just as good of an effect by giving them scheduled Tylenol as you do by giving them whatever your favorite antipsychotic is. And then the nursing home toolkit is actually very good. It has lots of different things in there, everything from music therapy to touch therapy, what the evidence is behind it, and lots of different resources there. And again, teepasnow.com. So, you know, feel free to review any of those that might strike your interest, but hopefully I've given you at least a few pearls today that that you can take back and use in your work. And thanks for all you do. This is obviously not easy to do this kind of work, so I appreciate what you're doing. And even if your families and your patients can't thank you, you know, you're doing the right thing.
Well, thank you so much, Dr. Ott, for, you know, for your personal and academic, giving us the benefit of your personal and academic experience in deprescribing antipsychotics. I think the Teepa Snow and Cohen-Mansfield references you made has our audience really interested, and that'll be another good reference for them to review, getting out of here. Tell me, how did it go in that dementia unit in the end, or in this new dementia facility?
So it was rough. It took over a year to get the right staff on board. A lot of those that had been at the facility for years realized that they could handle 1 or 2 or maybe even 5 patients with dementia, but 110 was too much. You know, we went through a couple of directors of nursing, a couple of administrators. The one social worker was there a really long time. Another one, you know, they've replaced frequently. The laundry people and the maintenance people who had been there, they did great. They did fine. But again, there was a lot of staff turnover. And it took a long time to kind of get into the rhythm of, you know, the activity programming. But the activity programming there was better than I'd seen at than any of the other facilities that I had personally worked at. So it worked, and the building is still dementia only. Obviously, I'm not there anymore, but they've opened other buildings in Indiana to, you know, have dementia only as well. So I don't know that it's like the one best approach. I think that there are certainly patients, particularly male patients, who do better in male only units. So I think there's a role for them, but I don't think that everybody with dementia needs to be in a dementia only building by any means.
Well, I want to open up for the audience. Do you have any questions for Dr. Ott right now? Not hearing. I think many people are endorsing Tifa Snow as well. You know, I wasn't familiar with her, so I am definitely going to check her out after this. And
you know, I didn't know anything. I mean, when I first got started working in this dementia building, I think I had been out of fellowship 2 years maybe. I didn't know anything. I didn't know how to manage these behaviors, and I went and I started doing all kinds of like online research and like looking at YouTube videos and just trying to figure out what in the world do we do with these folks, you know, trying to involve geropsychiatrists. And at that time there was not a lot of good information out there, and Tifa was absolutely the best, and I think she's still the best in terms of being able to do this kind of work and figure out what the issue is and being able to intervene. So if you've never seen her videos, I recommend the Lewy body one, the positive approach. She has one, I think, on frontotemporal behaviors as well. And she teaches actually specifically to like emergency service personnel, you know, so obviously that wouldn't necessarily be the one that you would get, but you know, there's a lot of stuff out there. There's not a lot of great stuff out there. And like I said, initially the Alzheimer's Association training wasn't very good. Then they, I think it was CMS produced the hand-in-hand videos, which if the facilities use them, great. But a lot of times they thought it was some sort of advertisement and they just threw it away. I think there's so much room for improvement, but really trying to understand the dementia behaviors as communication, I think, is really important, because if we look at it as, well, they're trying to manipulate me or they're trying to get my goat or whatever, that kind of an attitude prevents us from being able to really communicate with them and figure out what's going on.
Well, thank you again so much. I picked up a lot of things actually, and I would think I'm fairly skilled at this, but I still always learn from somebody who has been there and done it so much. And I think the activities part is an extremely important part that is I always struggle with that. We don't necessarily only have the 3 Bs, but we usually stop our activities, it seems, at 5. That's what I see a lot, and that's high behavioral time between 5 and 8. So I think maybe that is one thing that I definitely took away. Really insist. Kind of maybe I'm off here, but really insisting on having meaningful activities into the evening, when often some of these behaviors occur. I think that's a really important one. And then looking at the CNA personalities, I think that may be something also to consider. I hadn't really considered that. I was going more with the certification, and I think that's definitely good. Okay, well, anybody else would like to take advantage of Dr. Ott while she's here? Well, again, thank you, Monica. And I want to remind everyone that not many people have done the survey. Would you please do that? That is really helpful for us. Doing this survey, you can do it right now, or you can do it at your convenience. Would anybody like to share from the audience a recent success story on antipsychotic reduction, or a recent barrier that they encountered? This is really a teach all, share all session. We have we have 5 minutes left in today's session. So if you would like to ask a question or say or mention a positive experience. All right, so I think in that case, we would like to, you will all get, this wonderful slide set will be made available to you on our website, also with the references, the little booklets that may be a good investment for our facilities, as opposed to them staring at a screen and in one of those formal education services. I think these booklets look wonderful, and that may be something for your staff development coordinator or your dementia care coordinator. So if you have had specific successes, we'd love to hear from you, and we'd love you to share that knowledge with our other team members. And then next slide, please. Our next webinar is going to be August 18th, and this is going to be a presentation on something that I am always at sea about, and that's when is it the right time to consider withdrawing anti-epileptics and anti-seizure medications. There is a right time for this. I certainly don't know much about it, and I'm really looking forward to that section. And until then, please continue your teamwork with meaningful deprescribing. You've picked up a lot of good tips here today, and we'll see you back on August 18th. Thank you for all you do, and be well. Bye-bye.